Hi everyone, my name is Emily Blarski. I am a PGY2 pediatric pharmacy resident at Riley Hospital for Children at Indiana University Health today. And today we're going to be talking about how to care for our tiny humans and get the essentials you need for a pediatric rotation. By the end of today's presentation, you should be able to choose reputable pediatric disease state and drug dosing references for use on your pediatric rotation, and describe the basic drug dosing and pharmacokinetic differences within a pediatric population. First, I believe that pediatrics is a very polarizing relationship in pharmacy. People often either love it or they're terrified of it. However, while our pediatric dosing and some of our considerations may be different from that of the adult population, once you have the basics, it is not a scary population by any means. And so the goal of today is to go over those basics to help you succeed in a PEDS rotation. First, you definitely need to know what you're treating in your pediatric population. You might learn 1% of pediatric therapeutics within your pharmacy school courses. And if you take a pediatric rotation, you may make it all the way to 3% of the pediatric therapeutic world. So these are a couple of references that are very helpful when you do encounter an unfamiliar situation within your practice on rotation. Pediatrics in Review and Neo Reviews are both publications put out by the American Academy of Pediatrics. And the articles about these topics often contain information about the basics of that disease state, how we may treat that, and the steps in treatment and medication use for that unknown disease state. So often if I encounter an unfamiliar topic, I will Google whatever that disease state is with PEDS in Review or Neo Reviews behind it. Do make sure that if you are using these references, you are using the most up-to-date reference as they are published longitudinally. Second, you need to know how to dose the medications for your pediatric patients. As you, I'm sure, learned in school, we do weight-based or body surface area-based dosing in our pediatric population. Body surface area dosing is mostly for chemotherapy, so a majority of our drugs are dosed in a weight-based fashion, and it is important to know the weight-based dose of all of medications for your patients on a daily basis. And keep in mind that we do max our doses at adult maximums. It's also important to know how to calculate the renal function in order to perform a proper dose adjustment for your patients. The original Schwartz equation is likely the equation learned in school, and this equation uses a constant of K that is variable based upon age to calculate that creatinine clearance for your patients. In practice, many institutions commonly utilize the bedside Schwartz equation, and this uses a one constant of 0.413 no matter what the patient age is. So most of our patients, we will utilize this bedside equation. If you are on a NICU rotation and seeing a neonatal population, I do recommend still using the original Schwartz equation for your patient. Now that we've reviewed how to dose our medications, and we then need to go over what references you should use to look up these dosing references. Pediatric and neonatal Lexi drugs provided through Lexicomp is the gold standard for pediatric drug dosing. It's frequently updated, and it is important to make sure that you're utilizing the correct monograph when using Lexicomp. So there is a separate monograph for each drug for both adult dosing and pediatric dosing. So make sure when you're using your institutional access that you are utilizing that pediatric drug monograph. Micromedics has less specific pediatric information, but is good for toxicology reference. So if you do have a patient who may have taken too much of a medication, I do recommend utilizing Micromedics for the toxicology effects. Neofax is available through Micromedics and contains neonatal drug dosing. It's less commonly updated and does not contain monographs for all medications, but is a reference that you can utilize in a neonatal population. Harriet Lane is a reference that you may hear providers commonly refer to. It is a publication that is put out every 3 years by Johns Hopkins, and this is a reference that contains not only drug dosing, but also diagnostic information and lab monitoring information. So it is a publication, an in print, so not as commonly updated, does not contain all medications. So I do not recommend utilizing that as a first line for drug dosing. It's also important to keep in mind that your institutional guidelines may exist. Often order sets are automatically built into your electronic medical record for drug dosing, but keep in mind that just because these are in the electronic medical record does not necessarily mean they are the most up to date. Now that we've gone over drug dosing, we will review the basic pharmacokinetic differences of our pediatric population. Looking at drug absorption, oral absorption can be altered in the neonatal population due to an increased gastric pH, which may require changes in drug dosing. Neonates and infants also have increased intestinal motility, which can decrease the time available for drug absorption. Topical drug absorption is increased in neonates and children as they have a larger body surface area to body mass ratio, as well as thinner skin in the neonatal population. Intramuscular dosing absorption can be altered due to a decreased skeletal muscle blood flow in the neonatal population. And finally, rectal drug absorption is increased in the neonatal population. However, neonates also have an increased pulsatile contraction rate of the rectal muscles, therefore decreasing time available for drug absorption. Looking at drug distribution in our pediatric population, we often say that our neonates and infants are little bags of water because they do have an increased extracellular and total body water compared to their body mass. This means that drugs may have an increased volume of distribution. So this is something important to keep in mind when we are dosing aminoglycosides in the neonatal and infant period. We may need to alter that dosing based upon their change in volume of distribution. Serum protein levels are also altered in the neonatal and infant period. They have a decreased total albumin level, meaning less protein for drug to bind to. They have an increase in fetal albumin levels, and fetal albumin does not bind drug as well as non-fetal albumin. And they also have an increased total bilirubin in the neonatal period. And bilirubin can displace drug binding from protein in the serum. So overall, this means that drugs that are highly protein bound may have higher free drug levels in the neonatal and infancy period than in our older patients. This is particularly important to keep in mind when dosing a medication like phenytoin that is highly protein bound, and that free drug level can greatly alter both efficacy and side effects. As we know, many of our drugs are metabolized by our CYP enzymes. However, these enzymes are not all active at birth. The times listed here are the times to the start of CYP activity for the various enzymes. Looking at one of our most important CYP enzymes of 3A4, this does not start to have activity for approximately 1 week after a baby is born. And while activity starts within a week, does not reach full adult levels of metabolism until 1 year of age. So drugs that are highly metabolized by CYP3A4 can have very different dosing requirements throughout the first year of life, and we may need to adjust our dosing accordingly. There is also an age-dependent increase in plasma drug clearance in children less than 10 years of age that is independent of this drug metabolism that will affect drug levels. And finally, looking at our drug elimination in the pediatric population, there is a low glomerular filtration rate at birth. And over the first 2 weeks of life, there is a rapid increase in glomerular filtration and renal function. However, adult filtration rates are not reached for the first until 8 to 12 months of age, meaning that our dosing requirements of highly renally eliminated medications may change over the first year. It's important to know how to calculate the urine output of your patient to also track their kidney function on a daily basis. In pediatrics, we always report our urine output as milliliters per kilogram per hour, and a normal urine output is 1 to 5 milliliters per kilogram per hour. So it's important to know that for all of your patients every day. Finally, I'd like to leave you with some tips to succeed on your pediatric rotation. Don't be afraid of not knowing the answer. Your preceptors do not expect you to become pediatric experts in a 4 to 6 week rotation period. And we all encounter things that we are unfamiliar with on a daily basis still. Investigate those unfamiliar disease states because we do expect you to be unfamiliar with the things you're seeing in your pediatric patients on a daily basis. Determine if pediatric guidelines or standards exist. Often we do not have specific guidelines for our pediatric patients. However, if they do exist, it's important to know how they differ from the adult standards you may have learned in school. Look up all of your pediatric drug dosing every day for every drug and know that dosing in a milligram per kilogram basis. Know your patient's renal function and urine output on a daily basis, and bring a calculator so you can always calculate these 3 things. Talk to your patients and your caregivers while you're on your pediatric rotation, and take advantage of the opportunity to learn the unique caveats of communication with patients of varying ages, their parents, their caregivers, and the medical team around you. And finally, have fun learning new things while you are taking care of our tiniest patients. Thank you.